Okay, and we are live. Good afternoon, web shadowers. Thank you all for joining our session today. We are so sorry we were a little delayed, but thank you all for your patience. Today we have the pleasure of hosting Dr. Masood, who will be teaching us about pediatric cardiology. As always, please remember the Google form will be posted in the chat box and in the description of this video at the end of the session. With that being said, Dr. Masood, you can get started whenever you're ready.
Thank you so much. Sorry again for the delay, everyone. Just had some technical difficulties. So again, my name is Dr. Masood, or you can call me Imran. I'm a pediatric cardiology fellow currently in training. And today we'll be talking about pediatric EKGs. Just a little background about myself. So again, I am from Northern California. I went to medical school at Toro University, California. And I did my residency at Children's Hospital of Los Angeles. And then I'm doing my fellowship training at the Children's Hospital of Los Angeles as well. All right. Alrighty, so again, today's talk will be about EKGs. Now, again, the focus for this will be about pediatric EKGs, because again, that is my specialty, but a lot of what we'll talk about is also applicable to adults as well. So some kind of nice general information overall. So we'll start by just talking quickly about EKGs in general, how to interpret them, what all these little squiggly lines mean, and then eventually we'll get to some patient cases. All right, so it always helps to start by just reviewing normal electrical conduction of the heart. So again, electricity starts at the Cyanoatrial Node, which is up here. Let me get my laser pointer. So our Cyanoatrial Node, so this is also known as the SA node. I'm sure people have heard about this. This is a little bundle of cells that have what we call pacemaker cells that have electrical activity. And so in a normal conduction, there is first a signal that starts in the SA node and moves down the atrium until it eventually reaches the atrioventricular node, also known as the AV node. And again, if anyone has any questions throughout this process, please feel free to reach out. Once we're at the AV node, then that signal that gets propagated down the conducted system to the what we call the bundle of His and the Purkinje fibers. We sometimes just group these together to call it the His-Purkinje system. So after it passes the AV node, it goes through the His-Purkinje system. And these little fibers, you can see these yellow lines that are drawn out here, go all the way down the septum and into the actual walls of the ventricles themselves, and they actually activate the ventricles. So again, that signal tends to move down there. And then again, just to really flush this out completely, so our signal will head down the septum towards the apex, and then we'll move up the walls here. And again, just to recap that one more time, so that's kind of the general path of electricity that we're seeing throughout our heart. So again, very basic sort of overview of the electrical activity of the heart. It's a good place to start. All right, so now let's kind of make a little more sense of what these squiggly lines mean and how they relate to the heart itself. All right, so we'll start by looking at the first part of the electrical cardiac cycle, which is the atrial depolarization. So again, this is that signal we talked about that comes from the SA node and moves down towards the AV node. And this is the depolarization of the atria. And so we call this the P wave. That's that first deflection that we're seeing here. That's our atrial depolarization, which again, depolarization, for those of you who are not familiar with that term, essentially is the electrical activation of the muscles of the atrium. So we're calling this atrial activation. All right, next we're talking about the AV node. As we said before, we go from SA down to AV. The AV node itself is reflected as this interval right here between the P and this, what we call QRS complex. So the PR interval is what we're going to call it. And this is the amount of time it takes to get from the beginning of the AV node to the end of it. All right, the next step of our cardiac cycle is ventricular depolarization. So again, activation of the ventricle Purkinje system that we talked about before. So including these fibers going down the apex, up the walls of the ventricle. We call that the QRS complex. So the Q is this first downward deflection, the R is this upwards, and S is this late downward deflection. So that's called the QRS complex. So again, just reiterating the flow of electricity here. And then lastly, we have ventricular repolarization. So this is the resetting of the ventricle. So after it activates, it resets to get back to a normal state to get ready for that next signal to come in. So we call this the repolarization phase. And this is where we see this last deflection called the T wave. And that little U wave you're seeing at the end there, it's not really that important. We don't see it very often, so we're not going to talk about that unless anyone has specific questions about it. So really the T wave is the end of the electrical cycle. All right, just want to pause and see if anyone has any questions about that. I know I kind of ran through it a little quickly.
There aren't any questions coming in right now, but I'll type them into the chat box as they come in.
Okay, great, thank you. So we'll go ahead and move forward. All right, now the next part about an EKG that's important to understand is the axis. So this is essentially a way for us to figure out which way is the electricity going. And so I've put up this little wheel here as a reference point, and we'll come back to this a few times because it can look a little confusing when you first look at it. But the idea here is that we have a few main leads that we look at, and they each have a certain degree of angulation based off this wheel here, and we use this to help us figure out which way the electricity is going. So again, you'll hear me refer to lead 1, lead 2, AVF, AVR, here's AVR again, AVL, etc. So these are the things that I'll refer to throughout the talk today. So an important thing to remember about these axes is, again, the way the electricity flows will help us figure out what the general sort of directionality is. And so if we go back to the wheel here, so again, we have two leads I want to talk about today. So lead 1 and lead AVR. So these are general electrical sort of, we call them leads or directions. A general rule is that on your EKG strip, if the electricity is moving in the same direction as that lead, then you'll have a positive deflection. So I'll say that one more time. If your electricity is moving in the same direction that that lead is pointing, you'll have a positive deflection. For example, if lead 1 is going in this fashion here, which I've just drawn out for example, electricity is moving in the same direction as that lead, then the question is, will your signal be positive or negative? What do you guys think? All right, so if our electricity is moving in the same direction as a lead, that should lead to a positive deflection. So again, what we're seeing here is a positive electrical activity. So upright P wave, upright QRS, upright T. All right, I see a few questions in the chat. I'll get to those in just a second here. Now, okay, great. Everyone's saying positive, awesome. Now, same deal with now this lead here. If our electricity is moving in the opposite direction of that lead, of the way the lead's pointing, then our signal is going to be negative. And so in a normal heart, we often do see this pattern where it's positive in lead 1 and negative in AVR. Now, I think it's helpful to sort of think about this wheel in the heart itself. So again, thinking about the fact that each one of these leads tells us a general direction of flow, and they're going to just see the electricity. So I wanted to take a second and ask and kind of poll the group here. If we have a normal path of electricity, which leads should be positive and which leads should be negative?
There's just a bit of a lag right now in the responses coming in.
Okay, no worries. So a general sort of way to think about this is that if you remember, the SA node is the start of the electrical cycle. The SA node is generally at the top and rightward aspect of the heart. And so right where my laser pointer is generally where the start of the signal is, and it will move in this direction towards the apex. So again, I'll kind of draw that out one more time. So the normal path of electricity moves in this direction, sort of like top right bottom left. So again, from the SA node down to the AV, down towards the apex of the heart and pulse. So that being said, in a normal EKG, the positive leads should be lead 1, lead 2, and lead AVF. Again, the reason being is that those leads are pointing in the same direction that the electrical activity of the heart is traveling, so they should be positive in these leads. And by the same principle, you should have a negative signal in lead AVR if the signal is moving from the top right down towards the bottom left, because that's the opposite direction of what AVR is pointing at. Okay, so there are a few questions in the chat here. I want to take a second to answer these before we move on. I know, and again, this is like a crash course on electrophysiology, which is, it took me a long time to learn, so I completely get that there's going to be questions here. So please do not hesitate to reach out. So there is one question that says, at the T waves, are the ventricles contracting? So good question. So the T waves themselves are actually during ventricular relaxation. So that's after the ventricles have contracted. So they contract during the QRS phase. So this is the actual ventricular contraction component. The T wave is when there's repolarization of the ventricle, so that the electrical activity is resetting to get ready for the next beat. The next question I'm seeing here is, can you explain depolarization? So it says if you can re-explain the depolarization section. So if I'm understanding this correctly, the question is about depolarization itself. So let me see if I can try to draw this out, because it is a little bit tricky. But if we think about inside of our myocyte, so here's a normal cell, we have a certain amount of electrical activity outside, and electricity inside as well. So at a normal state, you have a little bit of an electrical difference across this cell membrane. And this is something that applies to neurons, applies to all their cells in the body. And whenever a muscle gets activated, what happens is that some of these positive, trying to circle that positive there. Some of these positive electrons will move into the cell. So there's, electrical activity that causes some change in the surface to allow these little positive ions to come into the cell. And what that does is it changes the electrical sort of signal that's existing right now. And so you can have a more positive signal inside the cell. So again, this is a very sort of simplified way of just thinking about electrical activity as well. It's a whole separate talk in terms of depolarization, repolarization. So I won't get too much into it, but the general idea is that you have a flow of electricity that's going into the cell that's changing the actual electrical sort of negativity or positivity of it. So what that means is that when you measure it on like an EKG, for example, what we're seeing, these little deflections are the changes in the electrical activity of the heart itself. So when we say depolarization, the depolarization phase is the part of the cycle where the muscle is being activated. And the repolarization is a phase where after all this positive stuff comes in, it now has to come back out and get reset. Because if the next, electrical signal tries to come in and activate this muscle, it won't be ready because it still has some positive stuff that's been sitting inside. And so there actually has to be a separate process to move these things outside of the cell. And so the cells have to reset. And so that resetting phase is called repolarization. So depolarization, it means activation. Repolarization is the reset to get ready for the next signal. If that still doesn't make sense, please let me know. I hope that answered the question. Let's see, next question I'm seeing here. Shouldn't each lead have positive and negative components throughout the cardiac cycle? That's a really good question. And so technically, there will be some aspects that are positive and negative. When we think about the general axis, we're looking at sort of the average flow of electricity, but we can get into the details of some of that. As you can see, even in a normal QRS, a slight negative deflection. Let me get this pen going again. So we have a little bit of a negative deflection here, then we go positive, and then we go negative again. So to answer your question, the leads will have a little bit of both for the most part. There are some exceptions to that, but for the most part, yes, there will be a little bit of both. However, the average electricity is going to be positive or negative in a certain direction. Now, the next question I'm seeing here is why would lead 3 not be positive? So let's go back to that picture. Just erase my annotations here. Right. So lead 3. So lead 3 can be positive. It just depends on, a lot of this goes back to just kind of how the leads are placed and everything like that. For the most part, if you think about it, the electrical signal is going down the axis of the heart. Lead 3 should be mostly perpendicular. If, in a perfectly sort of straight axis, this should be perpendicular to the actual electricity. And so what happens is that when you're perpendicular, you actually get a negative or a flat, sorry, I should say negative, you get a flat signal. So what's happening is that your leads are looking at the electricity in sort of one direction. It's like either goes towards me or away from me, and that's all I really know. So if a lead is going perfectly perpendicular to the electrical signal, it won't even see the signal. It'll kind of just sneak by it. So lead 3 can be a flat signal, or it can be a little bit positive depending on sort of the direction of the axis. And again, when I say that there's not much of a signal, there's a term for that. We call it isoelectric. It's just a way of saying it's neither positive nor negative. It's just kind of like a flat signal. All right. Before we move further, I want to offer if there are any other questions. These are great questions thus far, by the way. All right, now, not to complicate things further, we just looked at what we call the limb leads. And so these sort of Roman numeral and these letters here that we're looking at, these are the limb leads. There's also another set of leads called precordial leads. And precordial leads actually have a slightly different axis. And so it's more of a front to back axis, whereas the last one was kind of like a left to right. And so as you can see here, if you imagine this heart in 3D, you have V1 through V6. V1 tends to be the most anterior or the most forward facing, and V6 tends to be the most lateral or left facing. And then there's the spectrum in between. And so these precordial leads, again, are also helpful at telling us in general which way the electricity is flowing. If you have a lot of electricity that's coming towards the right side of the heart, you'll see very positive deflections in leads V1, V2. In a normal heart, the left ventricle is bigger, and so you'll see most of the electricity going towards the left. So V6 and V4, V5, V6 should be positive. All right. Another component about EKGs is the intervals. And so this is a component of time that we look at. And so the idea here is that we just compare between the P waves, between the QRS, the PR interval, the QT interval. We look at all these sort of components of time to get a sense of how well the electricity is moving through the heart. You'll sometimes see that if a patient has a sick heart, or they just got out of surgery, or after a heart surgery, for example, the amount of time it takes to go from the atrium to the ventricle, it might be affected. We sometimes see what we call AV block or heart block, which is another way of saying that the signal from the atria is not getting down to the ventricle, or it's taking a really long. For each age, you tend to have a slightly different normal range of intervals here. So here's the question: do doctors usually place this many leads, or just choose a few locations? That's a good question. I didn't comment on the fact that when you look at a 12-lead EKG, it's a combination of those limb leads and precordial leads. And so a standard 12-lead will have this right here. So a normal 12-lead should have lead 1, 2, 3, AVR, AVL, AVF. And then you'll also have your precordial leads V1 through V6. So this is a standard 12-lead EKG. There are EKGs that exist that have extra leads that you can look at, extra precordial leads, extra limb leads. Those are used quite rarely and only in the really complex electrophysiology patients. But for the most part, we just do 12 leads as a standard. That's a really good question. All right, so basic principle about EKGs, there's a lot we just talked about. We talked about the axis, talked about the intervals, the different cycles of the heart. One piece of advice that I have for wherever you all end up after, medical school or beyond is anytime you read the EKG is to always have a system. To always look at things the same way every time. For example, for me personally, what I do is I always start by looking at this bottom lead right here. So this bottom lead is called a rhythm strip. As you can see, it's lead 2. So what this machine has done is that it's taken lead 2 and it's just run it out over a longer window of time. So that you can look at, over a long period of time, how are the things related to each other? How are my PQRS, is the sinus, et cetera. So I always look first at the rhythm strip. So we can talk about what that means. Then I look at the axis of the actual ventricle itself, and I kind of compare the different leads to help me figure out if it's a sinus beat or not. Then I make sure it's a normal QRS axis. Then I tend to look at these precordial leads as well, and I make sure that they are sort of a normal reflection of the heart. So again, in a normal heart, our left ventricle tends to be bigger than the right ventricle. So the net sum of electricity should be going towards that left side. And so if you look at these left lateral leads, they are positive, and the right sides are mostly negative. They have these large negative deflection signals. So that's a normal sort of what we call R wave progression, just a fancy way of saying that the right side is negative and the left side is positive, which makes sense because the left ventricle is bigger. Most of the electricity is going that way. If you have a patient who has, let's say, right ventricular hypertrophy, or they have a really dilated right ventricle, then what can happen is because there's now more muscle, it means it also takes more electricity to get through all that muscle. So these right-sided leads like V1, V2, instead of being negative, they actually will be more positive because, again, what your machine is seeing is like, I see more electricity coming towards V1, more towards the front. Therefore, it creates this positive signal. So then the last thing I do is I look at the T waves to make sure they have a normal progression. I look at the ST segment, so the thing between the S wave and the T wave. And then I look at the intervals. I go back and I go back to this first one. I look at the PR interval, the QRS, and the QT interval. Also, thought process of going through EKG. And so this EKG that we're looking at right here is a normal EKG. So again, we'll kind of just quickly talk through it. So when I look down here, I see P, QRS, T, P, QRS, T, P, QRS, T. So it looks normal, right? There's a P wave before every QRS. So that's an important sign because sometimes you can have, arrhythmias where you have more atrial wave, you have QRSs, or you have an atrium that's firing off too fast or firing off more beats, extra P waves, and not so many QRSs. But here, there's a 1-to-1 ratio. There's 1 P before every QRS. Then I look at the axis here. So let's go ahead and pull up the wheel. If I could get it to load here. There you go. All right, so I know this is kind of small in the bottom corner here, but this is a general way to just think about how do we figure out the direction of electricity. So again, first of all, I look at lead 1. Lead 1 here, it looks like it's mostly positive, right? The majority of the signal is positive, so it tells me that some of it's going towards lead 1. Lead 2, also positive, so going down towards lead 2. Let's see here, AVF, also very positive as well, so going straight down. AVR is negative, so that tells me it's going away from AVR, which means it's going in this general direction here, which is great. And then AVL and lead 3, so these are the other 2 leads that we talked about on the sides here. Here, lead 3 is pretty positive, so that tells me that the axis is probably swung a little bit over this way because of the fact that we're getting a positive signal here. But for the most part, our signal is probably somewhere between lead 1 and lead 3 in this general direction because all these leads are positive. So that to me is a normal axis. There's a good question here. Is it normal to see no S in the QRS? Yes, it is. And so part of what determines the QRS is it depends on where the signal is being picked up. So this is where it gets into kind of the weeds and the details of what is an S wave, and I think it's kind of beyond the scope of what we're going to talk about today. Depending on which part of the heart this signal is seeing, it may not have an S wave. It just has to do with the sort of net sum of electricity. Yeah. Next question is, should the T wave be so much taller than the P wave? This is a good question. So in general, I don't think to compare the T wave to the size of the P wave. If you think about it, it should be larger because the ventricles themselves are repolarizing, and the ventricles are bigger than the atria. The P wave is just the atrial depolarization. So the T wave in general should be, but I don't often compare the size of those two. I don't think that's really something that's very useful. However, if you do have tall T waves, so we call these like sometimes peak T waves. So if you have a really sharp upsloping T wave that has a sort of pointy end to it, that sometimes can happen if you have high potassium. So that is something to be aware of too. All right, let me just check the time here. Okay. All right, so I'm going to move forward so we can start talking about some cases. I know this is probably a lot, but hopefully it will be a little more clear as we talk about some kids here. Okay. Before we go on to the cases, I want to take one more moment to see if there are any questions. All right. So we'll talk through a few cases of things that I've seen in my practice. So again, first one. So this is a 15-year-old boy who comes in your clinic. He was playing soccer and suddenly passed out. And, parents are concerned now because he, had this symptom. So I want to open this up now to the group to see what kind of questions you would ask. What else do you want to know about this story? What about this episode do you want to know? What's going to help you figure out what happened here? All right. First question is, has this happened before? No, this is the first time. He's otherwise a really healthy young man. He's been playing soccer. He's, playing varsity in high school. So no, it's never happened before. Family history. So this is sorry, I'm laughing because you'll start to notice that when you ask patients questions, it's important to ask open-ended questions. Family history sometimes can lead to people listing out the longest possible list of every cousin, aunt, niece, and uncle who had any type of health history, which I think for a learning standpoint is important to ask those questions and to know how to do that. It is also a skill to learn kind of how to get a more focused history and kind of getting a sense of when you ask family history, what type of family history are you looking for? So I'm going to ask whoever said family history to kind of clarify what type of family history and how would you ask that question. And then in the meantime, the other questions are medications. So he is taking a medication. He's taking ondansetron. Ondansetron is a medication that's used for vomiting. So he recently had a gastroenteritis infection and was vomiting and had some diarrhea. He was overall getting better, but had some nausea this morning before he went to practice. So he took some of that ondansetron. And again, the brand name is Zofran. You may have heard of that drug before, but generic name ondansetron. How did he feel before passing out? Any pain? This is an excellent question. So no, he just was chasing after a loose ball. And next thing you know, he just, last thing he remembers is waking up on the sideline, surrounded by his coach and a bunch of players. Any pain? No chest pain, no other musculoskeletal pain whatsoever. What is the weather like? So it was it was not too hot. It was like 65 degrees, typical day. How long was he past that for? So we think, again, it's not entirely clear, but the coach, picked him up, took him to the sidelines. They tried stimulating him a little bit. And by the time, the parents were called and notified, he started waking up. So we think it could have been maybe 5 minutes, maybe 10. We don't really know. All right, now it looks like we're going back to this family history. Are there any breathing or heart conditions in direct family? His grandfather passed away from a heart attack at age 65, but other than that, there's been no family history. All right, those are really good questions. Good job, everyone. All righty, so again, just to kind of recap what we talked about. So you're chasing after the loose ball, woke up on the sidelines. He's had no chest pain, no palpitations, dizziness, no family history. And again, recently had this gastroenteritis infection. So he's taking this medication, PRN, which means as needed for vomiting. Now, one more point I want to just make. It's really important that when you ask questions in the history, to be again, both broad and specific. So one question I always ask when it comes to chest pain is, do you have chest pain when you exercise? Do you have chest pain when and I'll ask the same question in 5 or 6 different ways. Do you have chest pain when you're walking upstairs? Do you have chest pain when you're, running? Do you have chest pain when you're really nervous about something? Do you have chest pain when you're, playing or being active, or playing basketball? Just trying to find ways to keep asking the question in sort of slightly different angles. Because sometimes patients will forget, and as soon as you say the word have you had chest pain with basketball? They're like, oh yeah, every time I am doing suicides at practice, I start having really bad chest pain and have to stop, but they forget to mention it otherwise. So it's kind of good to just get in the habit of asking those specific questions. In terms of family history, the other thing we ask about is the very common thing you'll hear in the pediatrics world, is always asking about unexplained deaths. So there is a sort of association with unexplained death being related to anomalous coronary arteries or some other unknown cardiac arrhythmia. So it's really important to just ask families, have you had any, sort of unexplained deaths in the family? Someone who either passed away in their sleep or had a sudden drowning episode that didn't make sense, kind of along those lines we tend to ask, because if those are positive, it makes us worry that, okay, there might be a arrhythmia or some sort of anomalous coronary vessel that could be explained to this stuff. All right, good job. So want to also just take a second here and now start thinking about what can cause syncope. So syncope is a word for passing out. What can cause syncope in children? Now, I could tell some of you already kind of have an idea based off the questions you're asking, but wanted to open this up again to see what kind of causes can you all think of. All right, I'm seeing a few things pop up here in the chat. So concussion, okay, great. Concussion is a really important one. That's a very hot topic as well. What other things do you want to ask about in the history when you ask about a concussion? And then I'm seeing a few other things like heat stroke. Again, heat stroke is really important. Someone asked about the weather. Dehydration, same deal, asking about the weather. It's important to also just ask, how people are doing with hydration. Low blood sugar is another one. So again, really important. Kids are really active, being outside. For the most part, a healthy child should not have low blood sugar, but it can happen if they're not, being nutritionally appropriate. Anemia, great, another good one. So, we need oxygen to get delivered to the body. If you're in a stressful state where you have to increase your heart rate, increase blood pressure, sometimes you don't have enough oxygen that you can carry to all of the tissues. And then, okay, so now following up on the concussion question, have you ever had a concussion before or any injury that may have caused a concussion? Great, so very important questions. So I think of those things as really important sort of prognostic factors for a concussion. We know that there's something called second impact syndrome. So someone who's had a concussion before who gets a second concussion is at risk for serious neurological injury. In terms of the history itself, if I'm worried about a concussion, I'll ask about trauma. I'll ask if they, if they're playing soccer, for example, did you go for a header or slider? Or were you trying to, again, going for a loose ball, sometimes jumping and going for a header, you might collide with someone, head-to-head contact, et cetera. And that would kind of tell me, okay, this is maybe a concussion. And then, of course, other contact sports, it's just important to take a good history on that. So a few things that we'll kind of just talk about. So you correctly all mentioned hypoglycemia, you mentioned dehydration. I didn't have concussion on here, so that was a good pickup for whoever said that. Orthostatic hypotension. So this is kind of a general term for when someone quickly stands up or, you know, is a little bit dehydrated and they stand up and try to move around, that their blood pressure can't compensate quickly enough for them to have, you know, a normal pressure, so they drop a little bit. Vasovagal is the syndrome that we talk about that's pretty benign, but it's this idea that if you have a sudden drop in your systemic vascular resistance, so let's say someone, you know, this is like a classic example, someone gets super frightened by something and they pass out, like we see on like TV. You know, the idea here is that you have this massive vasodilation of all the blood vessels, and so your blood pressure ends up dropping, and that someone can then pass out because of that. Hypertrophic cardiomyopathy, I mentioned that because, again, from a cardiac standpoint, it's a very important diagnosis you don't want to miss. This is something that can cause syncope or chest pain with exercise. It's a genetic condition that can be lethal if it's not picked up on correctly. And then arrhythmias, because this is the EKG talk, that will be the big focus of us today. Yeah, good job, everyone. That's a pretty good list. Alrighty, so here is our patient's vital signs. In the interest of time, I'm going to just say that these are all normal. And you go ahead and listen to the patient, and this is what you hear. So I'm not sure if the audio is going to work at all. Can you guys hear this or not?
Yeah, we can hear it.
Okay, great, thank you. All right, so does anyone want to describe what they're hearing here? Does this sound like a normal heart? Do they hear something abnormal at all? All right, I'm seeing some responses here. Someone said it sounds dusty and turbulent. Someone said it sounds like a sloshing noise. Someone said muffled. You know, these are all excellent observations. I hate to say it, it's just bad audio quality. But what you are hearing does sound a little funky, right? That kind of scratchy noise to it. That is purely just, I think, audio recording. For the most part, you hear two distinct sounds. We call that S1, S2, and there's no murmurs in between. So this is actually a normal exam, just with bad audio recording. So sorry about that. All right, so normal heart sound. And again, just kind of show this quick diagram here. When we listen to the heart, there's four main places we listen to. We do this right sternal border, left sternal, left lower, and the apex. Each one of these gives us a different sort of like view of the heart in terms of the valve that we're listening to. So not to get too into the details of this, but up here at the right sternal border, we listen for the aortic valve. Left, we listen to the pulmonic valve. Down here at the left lower, we listen to tricuspid valve. And then here at the apex, we're listening to the mitral valve. And so if you hear something wrong at one end that you don't hear at the other, that would cue you in to say, like, is something wrong with the mitral valve? Or if the aorta has an issue, you'll hear something more loudly at the right upper sternal border. And that's important if someone who has syncope. One thing I didn't mention before, but if you have aortic stenosis, this is more common in the adult population. But if you have narrowing of the main artery, which is the aorta, that sometimes can lead to syncope as well. And so if you listen over this area of the aorta and you hear a really unusual murmur, that might cue you in. That can be what's causing your patient's symptoms here. But in this case, we have a normal cardiac exam. Alrighty, so again, in the interest of time, we'll kind of skip past this question, but you know, in general, a kid like this comes in, I'm probably going to start with an EKG and an echo. Again, the history of someone being physically active and having symptoms is very concerning for a true cardiac issue. If they said that, you know, if the story had said, I was sitting at rest and then just had a little bit of discomfort, or, you know, we were watching TV and like something scary happened and I passed out, or, you know, heard some awful news and passed out, you know, those things would be a little bit less concerning for a cardiac issue. but anything that's with exertion, to me, it kind of buys you the full workup. So we're going to at least get an EKG and echocardiogram. You might consider some blood tests. Someone mentioned anemia, so you can check the hemoglobin level. You can check electrolytes as well. But this is the patient's EKG, or the echocardiogram, excuse me. So I wanted to quickly just show this in case you have not seen echo before. But this is called an apical 4-chamber view. It's just looking at the 4 main chambers of the heart. So we have our right atrium up here, right ventricle, left atrium, and left ventricle down here. So as you can see, subjectively, this ventricle has a nice squeeze. It's, got great function. The left atrium looks okay. We can't really see the right ventricle too well. It's a little faded, but the right atrium looks like a normal size as well. So normal echo. All right, but now we get to the EKG. So this one's very tricky. Now, I wanted to offer if anyone thinks they see what's abnormal with this EKG. So I'll give everyone like a minute or two to kind of look at it. And then I think what I'll do is I'll probably just drop a hint pretty soon because it is pretty complicated. Okay, I'm seeing some great responses so far. This is awesome. Keep it up. Okay, I'm going to start going through these one by one. These are some really great answers here. All right, so we'll start with someone had said the T area seems delayed. So the T wave seems like it's delayed. And if I understand you correctly, it sounds like you're saying that T wave is just kind of taking a while to start. So that is one important observation. So we talked about intervals earlier in the talk, and I kind of just ran through that real quickly. But again, there are certain intervals along the electrical signal, along the electrical cycle that are normal. And sometimes we have short or long intervals. So when we say the T wave is abnormal, I'm actually going to jump down to another comment someone made, which is that repolarization is taking too long. So the idea that the time it takes from the ventricle to for the time it takes for the ventricle to reset is taking too long. And so the other way we look at that is the QT interval. So the Q wave normally is at the bottom, at the end of this the beginning of the QRS right here. And we can measure out to the end of the T wave. We call it a QT interval. So that's a great point. We'll come back to that in a second. I'm seeing someone said the P waves are peaked. That's also a really good observation. They look a little peaked down here. These are actually normal though. And the way that we tell is that so the way I do is I usually look at V1. The reason why I look at V1 is that this is the most rightward and full, like the most anterior or straight sort of lead, which is the most rightward lead of the heart because the right heart is kind of sitting closer to the front of the chest. And so this tells us more about some of the right-sided structures. And so our Cyanoatrial Node or SA node will send a signal starting from here. If you have a really big atria, you can have a peaked P wave. Your P wave will be at least bigger than 2 millimeters. And so I tend to look in this area, and these P waves here, as you can tell, they're not as peaked and they're actually kind of small. So that's a good point that they look a little peaked here, but in the actual area to look at, they're actually not that big. AVF is weak. This is also another good observation. So it's a little confusing because it's like, why is there not really a signal here in AVF? So whenever I see this, I tend to look at the rest of the EKG to kind of get a sense of what's going on. So we're upright in lead 1, we're upright in lead 2. Looks like we're a little bit positive in AVL and negative in AVR. So again, AVR being negative is normal. However, lead 3 is also kind of negative. And so I do think this axis of the EKG is actually tilted a little bit up and to the left. And so again, we can talk more about what that means exactly, but I think it is slightly on the border in terms of being deviated. Someone said lead V1 to V6 are peaked. I'm sorry. V1 to V6 lead peaks are not as deep, but not sure if that's normal for peds. So I think if I'm understanding this correctly, the idea that the amplitude of this wave, so it's not going all the way down, it seems a little bit diminished compared to the rest. So again, I think in pediatrics, we do have different sort of voltages we look at for criteria. And for me, when I kind of look at it real quickly, the most important thing is that I want to see a nice R-wave progression. So I look at the fact that it starts downward in V1 and it ends up kind of slowly flipping up towards V6. So this actually seems pretty normal. The other thing is, like, when I have that table, which is kind of hard to, to look at this without knowing, but there's a table that has normal values for how big these waves should be. And this is going to be in a normal range. So again, it's just important to know the take-home point for that I want you all to know is that for pediatrics, we tend to have sort of an age-based approach as opposed to adults where you'll have, anything greater than X is considered too big or too small. All right, so excellent work. So the diagnosis here actually is a prolonged QT interval. So again, the amount of time it's taking for the ventricles to repolarize is taking too long. And so this is called long QT. One quick way, if you are just looking at this, is that if the QT interval is about 50% of the preceding R to R, that tells you it's probably going to be long. But another important take-home point is that you always have to sit down and do the actual calculations, look at the numbers yourself. So again, we didn't talk about how to calculate these things, but just looking at the actual values here, we can tell that this is actually going to be a prolonged QT interval. So good job. So we'll quickly talk about what that means. So again, long QT interval. This is very dangerous. It can lead to abnormal ventricular activity. There's actually this rhythm called torsades de pont. I think it's a French word that I'm going to completely butcher and trying to pronounce. But we call it, torsades de pont. And it's this idea that you have this varying amplitude of ventricular activity. So what you saw in the last screen was what the signal looks like when it's normal, but a long QT can progress to this rhythm right here. And this is that torsades signal we're talking about. This is very dangerous and can lead to sudden cardiac death. So why does this have it? Well, there are a lot of things that can cause prolonged QT, a lot of antibiotics, a lot of medications. Antiemetics actually can do this as well. So he was taking a medication called ondansetron, which would, again, can prolong your QT. And in someone who maybe already has a long QT at baseline, you worry that using a medication that can further prolong your QT can lead to a dangerous arrhythmia. So I'm seeing a question here. Why don't you see the delayed repolarization of ventricles on the echo? Great question. Unfortunately, we just don't have a good sense of electrical activity on echo. If you have a really abnormal rhythm like ventricular fibrillation or VTAC, sometimes you can see that, but otherwise it's really hard to make out any rhythm issues on echo. All right. So looks like we're getting close. We're actually past 3 o'clock here. So I don't want to take up too much of anyone else's time, but I want to quickly just show this next EKG. So in short, this is a little girl who came in with dizziness and has been having, some fatigue with exercise. And every time she gets up and moves around or goes upstairs, she just gets a little dizzy and has to stop to recover. All right, so again, I really apologize for in the interest of time because we are running late here. The biggest thing that strikes me about this EKG, again, starting with the rhythm strip, if we go in order here, and grab that laser pointer again. So again, just starting here, I'll look at this first rhythm. Is there a P before every QRS? I see a P here, I see QRS, I see a T, and then I see this other weird weights here. I'm not entirely sure what that is. Okay, next one, P, QRS. Here's a T wave. Okay, again, seeing another deflection. If you look closely, it kind of looks like this little deflection here looks very similar to this P wave. So again, P, QRS, T, and then a P wave. So what's happening here is that for every QRS, I'm actually getting 2 P waves. So here's 1 P, 2 Ps. I'm sorry, here's 1 P wave, second P wave, QRS, first P wave, second P wave, QRS. Could it be a U wave? That's a good question. So it could be, and part of the way we can differentiate that it's not is if you actually were to take a caliper and measure out the distance between these 2 P waves, it will march out perfectly with the next P wave. And so despite what's happening within the QRS, it should line up perfectly. Whereas a U wave will always follow the T, and so it may not follow this P wave pattern as well. Now, based off this rhythm right here, because we're at a pretty steady rate, it can be kind of tricky to differentiate the two. But I also think the thing that helps you is the morphology, so the actual shape of the P wave. It looks very similar to what we're seeing. So this little bump looks very similar to what we're seeing here. So it's probably a P wave. All right, so what we're looking at here is there are these extra atrial contractions, right? These atrial beats. So the P wave here, again, call it atrial depolarization, that happens but doesn't conduct down to the ventricle, right? We're seeing a P wave and it kind of just fizzles out. And then here we have a P wave that does go down to the ventricle, causes a QRS, which is ventricular activation and ventricular resetting via T wave. So this question of why is this happening? So what we're looking at here is something called, well, I guess I'm going to take a second here to see if anyone knows the answer before I give it away. Don't know what we call this? Yeah, AV block, exactly. So this is a form of heart block, or also known as AV block. The idea that the AV node is getting these signals from above, but it's not sending all of them down to the ventricle. So again, in a perfectly normal setting, your atria contracts, hits the AV node sends a signal down to the ventricle. Here we're seeing that the AV node kind of gets the signal and just for whatever reason doesn't pass it along down to the ventricle. So this is a form of AV block. And so again, I wanted to kind of just zoom in a little bit on what that looks like. Again, we have P waves that are just being activated, so the atria are contracting, but they're not sending signals down to the QRS. So that's why we're seeing, no signal here. Just as a quick learning point, there are several types of heart block. So not something that, we're too much about memorizing right now. Is basically the idea that there are differences. And what we saw in this patient was the second degree AV block. So this 2-to-1 block, the idea being that there's 2 P waves for every, 2 atrial contractions for every single ventricular contraction, or you can say 2 P waves for every QRS. Okay, someone asked a question, is Afib the same as AV block? So AV block is, that's a good question, because when you have Afib, you start firing off tons of P waves. So what's happening is that your atria, if you think about like a nice sort of muscular contraction, it should all squeeze together, right, in a normal contraction. Atrial fibrillation, all your muscles or all your myocytes are doing this. They're just firing off randomly, and there's no coordination whatsoever. So every now and then, some of these signals are going to hit the AV node and get across. So you'll see, as fast as the AV node can conduct, it's going to see all these signals coming from above, and it's going to down to the ventricle. So in a way, it kind of is, it sounds like AV block because not every atrial signal is going to make it down to the ventricle, but we don't really think of them in the same sort of group of disorders. And the reason being is that when you have Afib, there's really nothing wrong with the AV node. It's just that your atria are firing so fast that the signals don't always make it across down to the ventricles. But that is a good question because people will often, I've heard even, fellows and attendees even sort of use the word block in scenarios that's not always appropriate. I think it's because it's not always about the fact that your AV node isn't conducting. Block itself suggests that there's something wrong with your AV node or something wrong with the His-Purkinje system. But sometimes you can have rhythms like ectopic atrial tachycardia, which is something we see in kids, or SVT, which is called supraventricular tachycardia. In those scenarios, your P waves are firing at really fast rates and your AV nodes keep up. Doesn't mean you have AV block, it just means that your P waves are too fast for your AV node. Does that answer the question?
Yes, thank you.
Okay, great. That was an excellent question. All right, so quick overview of some of the things that can cause AV block: cardiomyopathy, autoimmune disease. You can be born with heart block. Actually, kids who are born to mothers who have lupus are also at risk for developing heart block. Lyme disease can actually affect the AV node as well. Being out here in California, I've actually never seen Lyme disease, but if you practice out in the East Coast, especially in New England, this is extremely common and something you'll definitely encounter. So I think that's actually all I have for today. Again, went through a lot of stuff very quickly on a very complex topic. So thank you all for participating. You all had some excellent questions and some really good points. So thank you so much. My email address is down here. Again, I'm Masood at chla.usc.edu. Please feel free to reach out. Any questions about, whether it be about pediatric cardiology, about applying the medicine whatsoever, if you're curious about the osteopathic route, any of the stuff, any just general advice you're looking for, I'm happy to chat with any of you. So please feel free to reach out. I know this year has been tough with COVID and it's hard to get out and get the experiences. So I wanted to offer my email address there. And then, of course, we are past time, but if there are any questions, please feel free to throw them in the chat here. Otherwise, you can always email me too.
Thank you so much, Dr. Masood. This was a wonderful presentation and so informative. I know I absolutely learned a ton. For everyone watching, the Google form has been posted in the chat box and it will be posted in the description shortly. Dr. Masood, if you have time, I'm about to put a few questions into the chat box for you.
Sure, yeah. Right, before we get into that, there's a question about what is AV Nrt. So this is what's called AV nodal reentrant tachycardia. So this is a form of supraventricular tachycardia. So there's an umbrella term called SVT, and SVT has, again, several types of arrhythmias in it. So AV Nrt, AV nodal reentrant tachycardia, is the idea that you have a circuit within the atria that goes into the AV node as it is kind of making its loop. That's kind of the most simple way I can explain it. Otherwise, it's a very complex rhythm. The idea being that, again, your signal is kind of going through the atrium and coming back, and it's also going down to the ventricle. It's sort of like these two little pathways. All right, so question, why did you choose pediatric cardiology versus general cardiology? This is an excellent question. So I actually thought I wanted to be an adult general cardiologist when I was, when I was growing up. When I was in medical school and undergrad, I just thought the heart is such a fascinating structure, and just, the physics that goes into it, like we talked about the electrical stuff today. There's so much more that goes into like the pumps and the flows and hemodynamics, and I just think all that stuff is extremely interesting. So that's what got me interested in cardiology in the first place. I later on ended up rotating with an adult cardiology practice during medical school. And I think it was, the medicine itself was interesting. I just got really tired of working with adults. I think it's just not for me. I had done my pediatrics rotation as my first rotation in my third year in med school, and I absolutely loved it. Peds is great. You'll notice, like, going through medicine, it's a very tough career. It's a very tough field, and you really have to love what you do. And I found that pediatricians just seem to be really happy. The fact that you get to work with kids, they often are not causing harm to their own bodies. which is very different from adults. You know, a lot of the adult heart problems are caused by years and years of bad habits or, you know, doing like unhealthy lifestyle, et cetera. Whereas kids, it's stuff that, you know, they're a little more innocent. They didn't really cause it to themselves. And so there's just like a sense of fulfillment is the word I'm trying to say. In terms of helping kids that I felt like I didn't really feel with adults. Kids also tend to just bounce back better. And, you know, I feel like I always have at least one interaction every day at work with like some kid says something super funny or does something super like, you know, kids are just hilarious. So it makes coming to work really easy. And again, it is stressful, don't get me wrong, but I do just kind of enjoy that aspect of the job. And so that's what led me towards pediatrics. There's a question here. Is there any way to find out if someone has any potential hidden cardiac problems that can be deadly? Yeah, so this is a really good question. And this is a big topic of discussion because obviously, you know, our job as cardiologists is to pick up on this stuff and we don't want to miss someone having a deadly issue. And so one of the first things that I like to ask is always good history about kind of what I mentioned before. Are you having symptoms with exertion, symptoms with exercise? And again, I'll ask the same 3 symptoms in every different scenario, like back to back. So it ends up being like 12 questions in a row. And I'm pretty sure the patients look at me like I'm crazy sometimes, but you'll be surprised at how sometimes when you ask in this sort of sequential manner, you tend to get people who are like, oh yeah, I do have symptoms with this. So for example, I'll say, do you have chest pain with exercise? Do you ever have chest pain with, you know, exertion? Do you have chest pain with playing sports? Do you have chest pain, et cetera? And then I'll go and do the same thing with palpitations. I'll do the same thing with dizziness, and then I'll ask shortness of breath as well. So those things help me sort of frame the concept of, does this person have a heart issue? And then the other thing that's helpful to know is, you know, the type of pain that someone has can also point towards a cardiac issue or not. So if someone describes the classic chest pain that is concerning for a heart issue is like a squeezing or pressure. So when someone has a lack of blood flow to the actual heart muscle itself, that tends to be the sensation they get. They feel like this crushing sensation or squeezing. I've had kids like tell me like someone's squeezing their heart. So that's to me more concerning. If someone says it's kind of a sharp pain or it's like a burning pain, you know, I'm a little bit less concerned, although you have to take the whole story together. And then the other thing that's helpful to know is the duration of symptoms. So if someone has chest pain that like sharp pain that comes and goes is gone within a second or 2 seconds, it's probably not going to be a heart issue. That tends to be more likely related to like the chest wall, musculoskeletal pain, something like that. But if someone says, kind of like in that story, like it's a 5-minute episode or 10-minute episode, that is more suggestive of a heart issue itself. And then to answer your question in a little more detail about finding out if someone has an issue. So if I hear something in a story that's kind of concerning, there's a couple of tests I can order. So one of them is called a Halter Monitor, also known as a Zio monitor. And this is basically like a take-home device that someone puts on their chest, and it's like a constant rhythm strip. And so it's an EKG that's running all the time. You know, at least our practice is to do it for like 14 days. And there's a button on there. So if someone is having symptoms like chest pain or palpitations, they can press the button. That way, when I go back and look at the report, I can say, when so-and-so was having symptoms, I can look at their strip and say, okay, there was nothing going on there. It was just a fast rhythm. Or, yeah, that you know, QT looks abnormal, or there's a weird P wave or something. So that helps me figure out dangerous rhythms. And then the other test is a stress test. So actually getting someone on a treadmill or on a bike, we can do a test where we put electrical leads on the body. As they're exercising, I can watch, is there ventricular tachycardia or some changes that suggest ischemia, et cetera. So those are kind of the ways to detect a hidden cardiac problem. I know that's a very long answer to your question. So another question, how exactly does a murmur affect the heart? So this is a very common question I get all the time. So murmurs are just the noise itself. And so a normal heart, as you have 2 heart sounds, S1, S2. We kind of talked about, you know, the classic lub dub. So the first sound, S1, is when your tricuspid valve and mitral valve are closing. So as soon as those snap shut. And then as soon as for S2, as soon as the aortic valve and pulmonary valve close, that's considered S2. So those are the 2 sounds that we're hearing. We're actually hearing the valves just snap close. So the reason why you hear a murmur is, for example, if the area, let's say you're ejecting out of your aorta, And the valve itself is a certain size. But if the size becomes narrow for any reason, that blood is now going to have a high velocity to get through there. And by doing that, it creates a little bit of like a flow acceleration. It can create like some turbulence. And so that can then lead to a noise that sounds like a murmur. So the murmur itself doesn't affect the heart. It's more that when you listen, you can hear extra sounds that we call murmurs. Now, sometimes murmurs can be completely normal. In kids, sometimes, they can have what we call flow murmurs or innocent murmurs. It's just the blood is just kind of swishing through the heart. And for whatever reason, it makes a lot of noise as it's going through, but it doesn't always mean there's something bad. So, and just to clarify that point, because I don't want people to say that, I don't want people to think that murmurs are always normal in kids. Most murmurs in children are normal. We do have certain murmurs that are dangerous. And so it just takes a little bit of a sort of, experience knowing which murmurs are dangerous and which ones are safe. But the murmurs themselves don't actually affect the heart. That's a really good question. Do you work with PAs? So I actually don't. I mostly work with NPs. And I'm not sure if that is just like a sort of institutional preference. I did go to medical school with a lot of PA students as well, and I did work with a lot of PAs during medical school, but I haven't actually seen too many of them in my day-to-day. But yeah, I think PAs are great. Their education is very rigorous. They were in some of the same classes as me in medical school. We shared the same lecture halls and like sat through some of the same basic science lectures and even some anatomy classes. So I think PAs are actually, it's kind of a great field to work into because you get a little more flexibility in terms of shifting between specialties, I guess is the right word. So I'm not sure if you had other questions about PAs in general, but I actually don't work with too many now. Do you ever just going into surgery? I did. So I actually did think about doing surgery for a long time. I really enjoyed the idea of being able to use my hands and like the satisfaction you get from, someone comes in with a problem, you go in with your hands, fix something and then come out. I think surgery is a difficult field. I think it takes a lot of dedication. I personally did not think the work-life balance was something that I was interested in. I think it's important for whatever job you decide to take and whatever specialty you choose is understanding what the commitment is like and what the work-life balance is like. Doing surgery residency is extremely grueling. I have friends who are doing it and just hearing the stories of how often they're on call and just how it's extremely stressful. Obviously, you're going into OR, you're taking a knife to patients. It's a big responsibility. And so I think the level of commitment it takes to do that is incredible. And I think the work-life balance, again, depending on where you go and where you work, to me just seems a little bit more than what I wanted to. I still want to have, at least a little bit of balance and have some family time in the future, et cetera. And so I didn't feel like surgery really lended me that opportunity. That being said, I think, I don't want people to shut off like certain avenues just because they hear that. I think you can find solutions that work in every field that you go to. And get sort of an idea of the general work-life balance. There's a question here about how many patients have you seen many cardiac issues with COVID-19 positive patients? So in my experience, not really. So COVID-19 itself, I have not been seeing cause a lot of cardiac issues. Again, this is my personal experience here, so this is not speaking for the general literature right now that exists around this. I know that in adults, it's more common that COVID-19, PCR positive infections is more likely to cause cardiac dysfunction, and it looks like even residual cardiac dysfunction. We're just starting to do some stress testing on our kids after they've gotten COVID as a way to further understand this as well. To my knowledge, though, I have not seen any significant cardiac issues. I will say that what we're actually seeing more of is MIS-C, so the multi-system inflammatory syndrome in children. And we are seeing a significant number of cardiac issues in those kids. And so it's not really COVID directly, but as a result of COVID antibodies that we're seeing out. And it's actually quite insane in terms of how much of that we're seeing right now. We think it's kind of the wave of like the Thanksgiving gatherings and getting into like December exposures that now we're manifesting as MIS-C. And just to kind of add on to that, I've had kids come in with, like I've done echoes in the emergency room on some of these patients when they first arrive, and they have really poor function, and they just look very sick and have low blood pressures, et cetera. So it's quite quite concerning. What are your hours like as a pediatric cardiologist? Am I on call? So yeah, that's a good question. Again, so I'm still a cardiology fellow. In terms of the call itself, so my general fellowship program does call about, so as a fellow, I do call like once every weekday, and then at least one weekend per month. So it's actually not very bad, I think, compared to residency. Like residency, I was doing call, 2 or 3 weekends per month, sometimes every 4 days, doing a 28-hour shift. It was it was pretty bad. But fellowship has been much better in that sense, where it's a little bit less frequent. The hours, they just differ depending on the day. So if I'm doing echoes for the day, it's probably a little more relaxed, like show up around like 7 or 8 o'clock and leave around 5. Again, if there's echoes that kind of happen late, I'll stay a bit later, but it's a little bit more relaxed as opposed to when I'm on service. So that means I'm rounding the ICU, I'm taking consults and e-consults, PICU consults, NICU, et cetera. Those days tend to be much longer, so I'll get in somewhere around 5:30 to 6 in the morning and probably leave here also around 5:30, sometimes 6 or 7, depending on the day. So it just kind of varies. And those weeks can be tough because you're staying 12 hours pretty much per day, like the entire week. If I'm on my cath rotation, again, same thing. Those 2 weeks can be kind of intense. So it really depends. In terms of the actual lifestyle attending, so once you're done with fellowship, it tends to be a little more flexible. That's just a general practice, and it depends on where you go. But the hours are going to be, again, probably similar to like your typical 8 to 5 or 9 to 5, depending on where you go, and then some call interspersed here and there. I think I missed a question somewhere up here. Why do you choose MD versus DO? This is a great question. So back when I applied for medical school, so this was back in 2012 is when I applied. At that time, I was more interested in doing primary care. So I thought I wanted to do like family medicine. I wanted to do a lot of global medicine. I wanted to go to communities and be able to treat all kinds of patients and all kinds of issues. I thought the DO model seemed to favor that quite a bit. It's very geared towards primary care. The OMT aspect of it, I also was a big fan of because it was, to me, it was like an extra skill that you can learn about and apply. And, in my mindset of I want to do global medicine and go out and do all this stuff, it seemed like a way to help people in a very resource sparing way. You're not having to bring extra equipment or any special testing. The skills that you can learn through hands seems like pretty great. So those are kind of the main things that drove me towards doing it. I think in general, DO schools, they are excellent for primary care, but they're also excellent for the other specialties as well. So I don't want to create this idea that that if you go to DO school, you have to do primary care. I mean, I'm an example of that. I'm not doing primary care. I'm in a subspecialty now. And I have several classmates who did surgery, from dermatology, ophtho, so all kinds of stuff. So I think really a lot of it depends on kind of that, when you're making that decision, it probably depends on that sort of mindset.
Thank you, Dr. Masood, so much for taking the time to answer all of our questions. We really appreciate it. And we really appreciate you taking the time to present to us today.
Yeah, it was my pleasure. I hope it was educational.
It definitely was. Thank you so much. And last thing for everyone still watching, just a reminder that the Google form will be open for another half hour from now. So just make sure you get that in before it closes. And thank you once again, Dr. Masood. We really appreciate it.
Yeah, most definitely. Like I said, my email address is up there, so please don't hesitate to reach out.
Will do. Thank you so much.